Thank you. First, let me thank the organizers for inviting me to speak in this session. It's a long way to come, and I really appreciate it. I will be talking about the vertical transmission, and what I decided to do is to take a twist, because we've heard and we've seen a lot in terms of the success of implementation of option B+, and seeing some of the issues from Malawi. But in this case, what I thought I would do is I would like to take you on a free ride into a busy clinic in Lilongwe, Malawi, in the capital, to actually zoom in to see some of the issues which are happening within the facility in order to make sure that we contribute to the management of the HIV vertical transmission. And I'll be presenting on behalf of my colleagues. So this is actually from WHO, looking at the evolution of PMTCT using of ARVs from 2001, using a prophylaxis for the mother and also for the children, and going up as far as looking at single agents and also looking at the double agents. In 2010, we see that the WHO made a recommendation and divided the options into A and B, and then Malawi took what is in some other quarters called a crazy decision, which was ambitious and brave, looking at instead of saying option B+, option B is not enough, because one, the fertility there is a 5.7, and the feasibility of use of CD4 count is a challenge, and also looking at the duration of breastfeeding, median being 18 months, of which the main reason of cessation of breastfeeding being a subsequent pregnancy. So then the decision was like, we better go on option B+. And after implementation of that, in 2013, WHO made a swift and made option B+ as a recommendation for this process. This also coming from WHO, just looking at the new HIV infections, low and middle income countries, and looking at complexity of option A and also inclusion of option B. 2009, over 400,000 new infections in infants, basically coming up to less than 3,000 infections in 2012, and extrapolating to make sure that these would still go down as we move into 2015. So really to make sure that we look at the current approach needing optimizing to achieve universal access in the virtual elimination of vertical transmission. Now, this is actually May, looking at also the same component of the cascade of the infections amongst actually pediatrics, and looking at the implementation packages from WHO, including the prongs of PMTCT, and knowing that in 2009, over 300,000, but really going down as we move into 2015 with the implementation of full of what WHO recommends into that. So now coming up to, as I said, that a free ride, zooming into the facility where I work, and knowing that implementation of option B+ started in Malawi in 2011, of course, lifelong ART, regardless of CD4 count and clinical stage, using a tenofovir-based regimen with an extended use of nevirapine amongst the infants. So after the implementation of the program in Malawi, from April 2011 to September 2012, there was a 7-fold increase in the number of pregnant and breastfeeding women who were started on ART. And Malawi, as of September last year, the general accurate cohort of ART, over 450,000 alive on treatment, and this is 74% coverage, using actually the estimates of the 600,000 from UNAIDS. And this is actually 81% for adults, but still low, 47% for children. But in terms of HIV ascertainment in antenatal clinic, being at around 83%. And with a 7.8% accurate prevalence of HIV within the accurate cohort of ANC throughout the country. Those who started on ART and retained in care at 6 months being 79%. And those actually who were found to be HIV positive within the clinic at 9% actually started on ART. So we looked into, in 2012, looking at the new infections actually in the infants, and looked at where are most of these actually coming from. And what you see is that almost half, the majority of these are coming where actually HIV is not ascertained, and seconded by those who were HIV positive identified but slipped through the cascade and were not started on antiretroviral therapy. So this looks at issues where we look at in terms of looking at the process of management. So Baira Hospital, where I work, 15,000 deliveries a year. It is a busy clinic within the city, and which is led by the Department of Health and other partners operating at the facility. So really having the family health unit, which provides primary and secondary and also part of tertiary care. At the same time, the largest also ALT clinic just within the campus. This is the way they look really is 2 meters apart within the facility. So all patients started from 2011, all women coming into to the center, then registered into the electronic data system using a real-time touchscreen platform. And PMT services integrated fully within the antenatal clinic. And with all the providers providing group testing, opt-out testing for there, including individual private result communication, dealing with psychosocial and treatment adherence at the facility. All those who are HIV infected started on ART on the first visit, and which is to make sure that from the guidelines in order to avoid the slip through. And monthly ART pickup coming up managed by the nurses at the facility. And all viral load is checked at 6 months and is continued every 2 months, because every 2 years, because Malawi opted with the viral load monitoring. Of course, the women are given Nevirapine on the first day in case of the outside the facility delivery. Those who slip through antenatal are caught up within the maternity unit, and those who are identified to be HIV positive, they are also started on antiretroviral drugs. And also those who slip through the areas, then come into postnatal, also they are able to pick it up, and the follow-up is also done within the antenatal. And then at 1 year post-delivery, the patients are referred to their clinic of choice for ART continuation, but most of them come to the Lighthouse Martin Prus Center, which is within the facility, because they're used with the system available there. So just looking at what we've seen so far in terms of registrations from 2011 up to December 2011, 31,000 registrations within the antenatal clinic, and the HIV ascertainment being almost universal. And then HIV positive about 14%. This is higher than the national prevalence because this is in the capital city. And then coming up to the ART status, also coming up in terms of uptake at the day of initiation, being accurate about 99%, 30% already on ART as they come to the clinic, and accurate 70% coming up started at the clinic. In terms of those started on ART, 82% accurate are those pregnant, and 18% those who are accurate breastfeeding. Coming up to retention, 54% retained in care at the facility. I would draw your attention where I would talk more in terms of those who defaulted and also those who transfer out, because this is the area where I would like to understand what is happening to these. So if you take a take-home message for this Kappenmeier, is really to say that, because we're saying starting on the first day, and you see that the dropout is really those who come in on the first day and then they don't come on subsequent visits. This is also into the general service, whereby over 90% have at least one antenatal visit, but delivery to the health facilities below 60%. So really, most of these women have not really started on ART. They've just picked up the bottles and they are going. So this is an area of intervention as we're dealing with vesical transmission. But otherwise, if they come back, retention actually is sustained over the period of time. Well, immediate ART or deferred ART, that's starting on the same day or starting actually probably the following week. At the facility, they started on the same day, while in other sites in the country, because they are doing probably 1 day a week for initiation, they will come in the next actually day or next week. Immediate initiation, there's a high initiation uptake on the day, but lower retention because many defaulters are actually likely to be non-starters. While if you defer, we see that some of them actually we have a lower initiation, lower uptake, but you have a higher retention because having a smaller but more motivated cohort. So in terms of the approach overall, looking at remaining unclear, and this is what we are working at the facility. The good news, though, working quite well, is that 94% of women retained in care have actually at least above 95% adherence. And at 6 months, the viral suppression is actually 96%. These are below 1,000 copies. And we have a tracing program where we look at all the women who are not able to come back, and we're able to pick them up in 21 days rather than the 60 days in the national program. And this is what we understood quite well, to say that out of the 754 patients who were not able to, who did not come back to the clinic, 60% were not able to trace them because they did not have actually proper addresses. Or because we are in the city, some of these actually have moved on. Those 40% about a successful actual tracing, we saw that 33%, which is a third, these are transfer out. These are silent transfers, so there's no documentation that they move on. This is a success of national scale-up because they have many sites where they would go. But 64%, these are alive, and some of them, actually about a majority of them stopped, and also others are on treatment, but they're picking up from alternative routes. These are uninterrupted accurate treatment regimens. So early infant diagnosis, continuing to do accurate HIV testing at 6 weeks, 2 months, 12 months, and 24 months to look to pick up on the infants who have been exposed. And out of the 653 exposed infants who were registered between the period we are talking about 81% had at least a PCR test with a 4.8 actually confirmed HIV infected from the PCR. And those actually, the older ones had a rapid test in 14%, and 11% were confirmed with HIV infected. So overall, being about 5.8, which actually is just falls shy for the actually less than 5% of virtual elimination of vertical transmission. However, the major limitations actually are in the early infant diagnosis. This is really where actually a lot of investment needs to come on. And this is also hinging up to the actually people, women who default from ART are unlikely to bring their babies for testing. Therefore, these are the babies who are at the highest risk for actually getting the infection. So therefore, the inverse care law applies strongly to the early infant diagnosis. So in conclusion, what actually I've taken you through by zooming in into this, what we see here is that on at the facility busy like this one, HIV testing uptake is almost universal. And then when you look at on the day of initiation, uptake is also high. But we need to understand to say that because they've taken the medication, but then in terms of what happens when they go, it also fits within the general accurate health also for the country. For women who remain in care, adherence appears to be good, and we've seen that. While virologic suppression rates are also high at this facility. Vertical transmission, as I mentioned, within just falling shy within the 5.8, and we're talking about less than 5% of the visual elimination which we are targeting on. So just to mention that significant rates of early loss to follow-up are observed, and many women likely to have never started ART, as I mentioned before. And fear of consequences of disclosure of status to partner is likely a significant contributing factor. And we've done some qualitative research, and we see that as in terms of, this is a day whereby they're coming in for their antenatal, they're knowing their HIV status, they started on ART, they've not discussed with their actually spouses or any other person. This can be an issue actually when you're dealing with actually adherence. So there's need for further strategies to enhance psychosocial and adherence support, and this has been discussed with the previous speakers. And we have engaged the Mothers to Mothers program with the expert mothers, mentor mothers, to deal with the first day of initiation, to talk more, because the nurses are busy enough that they could be able to take more time to manage the patients at the facility, to spend more time to discuss issues of ART. So I think with this, I would like to thank my colleagues whom I work with at the facility, and also the funders who put in some support in order for us to do the program. And thank you for listening.